Hello, welcome to our Health Matters webinar, Is Employee Health Insurance Failing Americans? I'm Michelle Levander, Director of the USC Center for Health Journalism. Thanks for joining us today. In this webinar, we'll explore the crisis in employer health coverage, one that has gone largely under the radar as America is consumed by competing visions around health reform and the expansion of benefits launched under President Obama. Job-based health plans have become unaffordable for a growing share of the 156 million Americans who rely on them. Against a backdrop of rising healthcare prices, we've seen soaring deductibles and out-of-pocket costs, prompting hard decisions by employees on whether to make a doctor visit or leave prescriptions unfilled. During our webinar, we'll hear some new insights on this growing trend that come from a survey jointly produced through a collaboration between the Los Angeles Times and the Kaiser Family Foundation. We'll hear from three expert speakers: Larry Levitt, Executive Vice President for Health Policy at the Kaiser Family Foundation, who will discuss the survey findings in the context of broader trends; Noam Levy, who writes about national healthcare policy for the Los Angeles Times out of Washington, D.C. He'll discuss how he brought the survey alive with real people, as well as how newsrooms and reporters can collaborate with researchers as he did. And Dr. Arnold Milstein, the Medical Director of the Pacific Business Group on Health and the Director of the Clinical Excellence Research Center at Stanford University School of Medicine. He'll discuss employer coverage trends and stark choices in the face of rising healthcare costs. This webinar is offered thanks to the generous support of the National Institute for Healthcare Management Foundation and the Commonwealth Fund. You could tweet about the webinar at the hashtag #HealthInsurance. A word about our format today. We'll be hearing from our panelists first, and then we'll turn it over to our audience for questions. Because we have several hundred people on the call, we'll ask you to write your questions in the control panel of GoToWebinar. You can also write us there if you're experiencing technical difficulties. We will be archiving this webinar at centerforhealthjournalism.org. Now, let's turn to our speakers. Larry, why don't you get us started in thinking about just some of your broad findings from your survey?
Thanks, Michelle. The Medicare for All debate that's been occurring primarily in the Democratic presidential primary has put the spotlight on employer-based health insurance. Medicare for All, under current proposals, would eliminate virtually all private insurance and certainly all employer-based insurance. And this makes people understandably nervous, giving up something that they know, if don't always love, for something that is new and perhaps unknown. But the fact of the matter is that employer-provided health insurance has become less available over time, and in many cases less affordable as deductibles have risen rapidly. Lots of the oxygen in the healthcare debate has been spent on the Affordable Care Act and the insurance marketplaces where people buy coverage on their own. But the reality is that that's a very small share of the healthcare system. Roughly 10 million people get coverage through the ACA marketplaces. Employer-based insurance, on the other hand, is by far the largest source of health coverage for Americans, covering over 150 million people currently. Now, over the long term, the trend has been down for the share of the non-elderly population, people who don't rely on Medicare, who get employer coverage. In 1999, roughly 2 decades ago, over two-thirds of non-elderly people got coverage through an employer. That's now declined to 58%. As costs have risen, as the labor market has shifted, fewer employers are offering coverage and fewer people are taking up that coverage due to the cost. In recent years, there's been a slight tick upwards in the share of people with employer coverage as the economy has improved, but still the share of the population with employer coverage is nowhere near where it was 2 decades ago. Now, probably the biggest challenge in affordability for people with workplace coverage is rising deductibles. The average deductible in an employer plan is now over $1,500 a year, and the average deductible has tripled over the last decade, while wages are up just 26%. This is putting healthcare out of reach for many low-income workers, and frankly, even middle-income working families who find they can't afford these deductibles. One way to illustrate this through a concept we developed is what we call Deductible Relief Day. And this is the day in the year when average health spending for people with employer coverage exceeds the average deductible in that year. And as you could see, this Deductible Relief Day is falling later and later in the year as deductibles rise faster than health spending overall. So in 2006, February 28th was the day in which the average person might meet their deductible based on average spending. That's now climbed to May 19th. So as people are meeting their deductibles later and later in the year, more people are paying for their full health expenses out of their own pockets, and it makes people feel like they're getting less value from their health insurance. Now, under the ACA, people who buy insurance on their own through the marketplaces are eligible for subsidies that are scaled to their income. And those are subsidies that help people pay their premiums as well as their out-of-pocket costs like deductibles. Those subsidies do not exist in employer-based insurance. And the result is that healthcare is a big burden on people who are lower income, and particularly people who are lower income and in poor health. And if you look on the left side of this chart for people with incomes under 2 times the poverty level, the average share spent on premiums and out-of-pocket costs is 14%, but that rises to over 18% for people who are both low income and in fair or poor health. Now, when we think about high deductibles, it's important to remember that a lot of people don't have a lot of money in the bank to cover an unexpected medical expense. Only about half of single people have liquid assets available to cover an unexpected medical expense of more than $2,000, which is not an uncommon deductible these days. So if you don't have the dollars to cover a deductible, if you don't have the money to cover a deductible, your insurance in many ways feels like uninsurance to you. Now, to get a better understanding of the experiences of people with employer-based insurance, we did this survey in partnership with the LA Times. Noam's going to talk more about the overall partnership and his reporting under it, but I want to go through some of the survey results we uncovered. Probably the kind of top line result is that many people with employer-based insurance say they have faced some kind of healthcare affordability challenge. 40% of people say they or a family member have experienced some type of challenge affording healthcare in the last year. These are primarily challenges affording out-of-pocket costs, problems paying medical bills, difficulty meeting your deductible, dealing with surprise medical bills. Some people also have trouble affording their monthly premiums, but that falls further down the list of challenges. And for many people with employer-based insurance, that monthly premium is somewhat hidden because it's just coming out of their paycheck before they even see their take-home pay. Now, the numbers, of course, are important, and that's why we did the survey, but people's stories are important too. 17% of people with employer-based insurance had to make some kind of difficult sacrifice in the last year to pay for healthcare. And the stories that people tell illustrate that even in a working population, people with some resources, many struggle financially to make ends meet, particularly those who are sick. And these stories, help form the basis of Noam's reporting, which he'll talk about. The survey shows that the affordability challenges are most acute for people who face what you might think of as the triple whammy: people who are lower income, people with chronic health conditions, and people with high deductibles. People with chronic conditions in particular report making significant changes in their lives to pay for health care. Some of these may feel like discretionary changes. Others are kind of major changes in their life circumstances. So it's everything from putting off a vacation or a major purchase to cutting back on food, clothes, other household items, using up all their savings. And remember that people in many cases don't have a lot of savings to to cover an unexpected medical bill. In many cases, people do find a way to make it work when faced with a significant health expense, but it can mean borrowing money from friends, going into debt, or taking out a loan. Now, most people feel that the current health insurance system works well for people like them. And this is one of the challenges of Medicare for All, which would upend the employer-based insurance system and move everyone into a public plan like Medicare. People are understandably nervous about that change, but they also there's a significant status quo bias in healthcare, where people are more comfortable with what they know and already have. But it's not true for everyone, particularly for people with higher deductibles. They're less likely to feel like the current health insurance system is really working for them. Now, one of the things that frustrates people with insurance are what you might think of as microaggressions in the healthcare system. And one that's gained a lot of prominence lately is surprise medical bills. These are bills where if someone goes to an emergency room or someone goes to an in-network hospital, they can still be faced with out-of-network bills. It might be an anesthesiologist, it might be a physician in the emergency room, and these when patients are faced with these out-of-network bills, healthcare providers can impose what are known as balance bills. So healthcare providers can charge over and above what they are getting paid by the insurance company. There's an active debate in Congress to address these surprise medical bills, and our analysis shows that they happen quite often. 18% of emergency room visits, 16% of in-network hospital stays result in an out-of-network charge and a potential surprise bill for patients. To show that so much of healthcare is local, these surprise medical bills vary tremendously by state. States like Texas, for example, have much higher rates of surprise bills than states in the upper Midwest, for example. And this is true for emergency visits, as you see here, and also for inpatient hospital stays. Now, whether Congress can come to a consensus and address surprise medical bills is hardly a slam dunk. There's an emerging consensus that patients should be protected from these surprise bills, but there is an ongoing fight among major industry groups, health insurance plans, hospitals, and physicians about who should bear the burden of these out-of-network charges. And for example, there an effort to expand protections for surprise medical bills in California has stalled due to pushback from the hospital industry. So as we debate, in the election, large changes like Medicare for All, it's important to remember that healthcare industry groups are still quite powerful in making progress on affordability. The affordability challenges that people with health insurance are facing is an uphill battle. So I think I'll leave it there and turn it over to the other speakers. Thanks.
Great, thank you so much. We are going to turn now to Noam and hear from him about how he took this data that both he and Larry Levitt at Kaiser Family Foundation generated and turned that into stories.
Thanks so much, Michelle. And thank you again, Larry. So I thought I would talk a little bit about our project, how we sort of came to think about it and what we did, and then hopefully share with you a few reflections on kind of where I think sort of this might be useful and for other publications. So we sort of thought about doing this series in large part because we felt this was sort of an uncovered story. It was sort of, in many ways, I think, hiding in plain sight. Every year, healthcare journalists like me would get these wonderful annual employer surveys that Kaiser did, showing the sort of inexorable march upward of deductibles, and it would produce, maybe a short story that was buried somewhere inside the business section. And we spend so much time writing about Obamacare and the fight over the politics of healthcare in Washington that we sort of felt we were missing this huge story, and we wanted to take a deeper dive into what was going on and what the implications were of what really has been a revolution in what employer provided health coverage looks like. So we approached the Kaiser Family Foundation and a couple of other nonprofit research think tanks here in Washington to talk a little bit about ways that we could dig into this a little bit. And the poll was the sort of the largest project, research project associated with what we did. But we really sort of conceptualized this as kind of a three-part exercise. I mean, we wanted, everyone knew that their deductibles were going up. So there was sort of, in some level, we weren't going to reveal anything that was a huge surprise to anybody, but we really wanted to ground what we were writing in some solid data. And Kaiser Family Foundation has been producing terrific data for their employer-provided reports for years, and we wanted to build on that with the poll, which would help us sort of get into some of the questions of what people were actually experiencing out there. And then we also wanted to look a little bit at sort of real life data on how people were actually using these high deductible health plans. And so we approached the Healthcare Cost Institute here in Washington, which has an interesting data set of commercial health insurance claims. And we were able to think about how we could use that data set to look at particularly how people who have chronic medical conditions like diabetes, how they were using healthcare if they had a high deductible plan compared to those who weren't. And our third research partner was the Employee Benefit Research Institute, another Washington, D.C. think tank. They're interesting in part because they have some very interesting HSA data from large employers. These are these health savings accounts, which of course were set up 15 years ago, in part to advance actually the use of high deductibles, but they've become problematic for a couple of reasons, which I'll talk about in a minute. So we had that data piece. The other thing we really wanted to do was kind of dig deeper into what academic literature had shown about what was going on out there with the way that insurance deductibles were affecting how people seek or don't seek medical care. And again, there's a lot of really interesting work going on out there by researchers across the country, but another academic article in a journal that perhaps people aren't terribly familiar with about how much people with multiple sclerosis have to pay for drugs probably isn't going to generate a news story. But when we started to put all those research articles together, it started to really build out the picture of kind of what this was happening. And then the third piece really was stories, as Larry mentioned. I mean, that's sort of, I think, in some ways what's our core competency, if you can call it that. But we can find stories, and we explicitly designed the poll with the Kaiser Family Foundation to help generate stories from people by giving poll respondents an opportunity, as KFF does with I think all of its polls, for people to say whether or not they would be willing to be contacted by a reporter. We supplemented the data that was the contacts that were generated through the poll with some more traditional news gathering, story gathering techniques. I did a lot of times speaking with disease groups, American Cancer Society and the like, because many of them maintain story banks of people that they've helped. We did a call out online, allowing readers of the LA Times to fill in information about their own experiences, which generated quite a number of stories. And then in other cases, the next story that we have coming out is about how people rely on charity increasingly if they have health insurance. I just spent a lot of time trolling through GoFundMe pages to try to convince people to talk to me. So those were the sort of elements of the story. I'll take you quickly through kind of what we did. Our first story, which is here, really focused on trying to put some real stories and real data with the pain that people were experiencing out there. Larry showed those little bubbles of people's responses, and I think one of the things which really struck us, and I think it struck the people we worked with at KFF, was that even though we all knew that deductibles were rising dramatically, we knew that people were having trouble paying their medical bills, when you actually saw the kinds of things people said they were doing, like going without food or thinking twice about bringing their kids to the doctor, it sort of added a level of poignancy to I think what's happened with health insurance over the last 10 to 15 years. And we really wanted to try to capture that, particularly in the first story, which really dug into kind of the incredible amount of sacrifice and suffering that millions of Americans who have health insurance are experiencing. So we had a story that dug into that at a high level, as well as a profile of one family we went to go visit in Topeka, Kansas, who were living paycheck to paycheck and underwater in thousands and thousands of dollars of medical debt. We turned for the next story to the particular challenges that Larry mentioned that people with chronic medical conditions face. And one of the this actually was a story that was built around a profile, really, of this woman, Wendy Matney, who lives in northeastern Tennessee, who suffers from epilepsy, and as a result has fairly frequent seizures, which require or result in ambulance calls and trips to the emergency room. Because she has a form of epilepsy that's not controlled well by medications, which is not uncommon, she has relatively little control over her healthcare utilization. But because she's in a high deductible plan, every trip to the emergency room resulted in thousands of dollars of medical bills. She and her husband ultimately had to declare bankruptcy, and she got to the point where she was literally pleading with her friends and family not to call the ambulance if she had a seizure. One very interesting part, I think, of what's happened with high deductible health insurance is the degree to which it is increasing people's feelings of frustration and anger, as well as exposing, I think, deep kind of divisions across the country in the way that people get their health insurance and how they feel about it. Larry pointed to the top line numbers in the poll, which indicate that, somewhat surprisingly, a large number of Americans remain relatively satisfied with their job-based coverage. But if you start digging into that further and you look at people who have higher deductibles, we find that levels of frustration and anger are considerably higher. The other interesting facet, I think, of this particular part of the story that we were looking at was the degree to which, particularly sort of lower middle income American workers were getting squeezed by a system that in some ways protected the very low income by making Medicaid and the Children's Health Insurance Program available to that subset of the population, which is largely cost-free for people who are on those programs. And at the top end of the income ladder, wealthy workers benefit not only from working for companies that typically require them to put less of their paycheck into the health benefit, but they are able to avail themselves of the benefits of health savings accounts by putting away money in these tax-preferred savings vehicles. And the result is that the people in the middle really are feeling the brunt of this, while people at the upper and lower ends, in some ways, are better positioned to weather what's happened with this dramatic transformation in insurance. we published 3 parts of the series so far. We have another 3 or 4 coming where, as I said, we're going to be looking at how medical healthcare charities have increasingly come to prop up and support people who have health insurance, which is a change in some respects from how many of these charities operated in the past when they primarily served people who didn't have health insurance. We're going to be taking a look at an international perspective. I did some reporting in Europe this spring, not only in sort of traditional single payer system like the UK, but also in more recognizable systems in Germany and Holland that are organized a bit more like we are, just to highlight how out of step the U.S. increasingly is with other wealthy countries where concerns about out-of-pocket costs for healthcare are in many cases unrecognizable for residents of those countries. And we're going to take a look at also how much the promise of high deductibles, of converting patients into consumers who could shop around for healthcare, has proven illusory. Really quickly before I turn this over to Arnie, just a few thoughts on kind of where I think this hopefully could be useful for other writers, healthcare reporters thinking about this. I just make one observation. I don't think it's necessary to do a big national poll to sort of get at sort of what's happening in communities around the country. This is sort of, as I said, kind of hiding in plain sight. But I will say that sometimes I think reporters are reluctant reluctant to approach researchers to form partnerships. But we were tremendously happy with our work with KFF. KFF has a lot of experience in that regard, and so working with kind of pros like Larry is a real joy. But my experience is that a lot of academic researchers, either independently working at universities or in sort of smaller research shops like EBRI and HCCI, were happy to provide basically in-kind contributions in their research time to dig into these issues with the promise that we could that their research could get exposure in what we're writing. One other thing that I thought might be worth thinking about, and this came up in the context of the third story here about sort of the political anger that people are feeling, is that I heard from a number of pollsters around the country that said, amen, this is exactly the kind of stuff that I've been hearing in focus groups that we do for political candidates around the country. And focus groups are a lot cheaper and easier than big polls. And I thought that might be one thing that folks could think about in terms of how to kind of get at the experiences that people are having with their health insurance and how that's making them feel, particularly in this political season. So I'll stop there and look forward to your questions. Thanks.
Thank you so much, Noam. We're going to hear next from Dr. Arnold Milstein, and he's going to be sharing some of the employer perspectives he hears as medical director of the Pacific Business Group on health.
Thanks, Michelle. I first became acquainted with I'll call it the buy side of healthcare in the 1980s when I was working for Medicare. Medicare at that point was beginning to recognize, as many private purchasers of healthcare began to subsequently realize, that healthcare spending per person was rising a lot faster than revenues were coming in at that point to the federal government, and simultaneously, even though it wasn't all that evident in the early 80s, much faster than money was coming into either public or private employers. And so it was about 35 years ago, mid 80s, that the CEOs of large employers began saying, maybe we should begin to be a little bit more active than what we've historically done, since World War II, which is simply picking a friendly insurance broker, who then picks a a friendly insurance company, and then we allow our employees to go to any doctor they want. And back then, there was not much in the way of deductibles and patient cost sharing. Maybe we need to do a little bit more, because we can see that our spending per employee is rising a lot faster than our incomes, regardless of whether we are public employers like, let's say, CalPERS or Massachusetts Group Insurance Commission, or we're private employers, be it Chevron or Walmart. So beginning in the 1980s, they began to say, let's take the same purchasing approach that works in our core businesses and apply them to this area of expense, which is how much of our employee compensation we pay for health benefits. Let me move ahead to the next slide. So, one of the intuitive places they look is, well, when we're buying carpeting for our offices, or when we're buying pencils or various parts of our supply chain, there are inevitably some suppliers that are more cost effective than others. And so this just shows you a chart produced by a collaboration of accountable healthcare delivery systems, that is, healthcare delivery systems in California that are accountable for cost of care and quality, and insurance companies and large employers. This is an organization called the IHA that's been around for a long time, and has basically said, let's work together to see if we can improve the efficiency with which California's accountable doctors and hospitals deliver health care, and presumably moderate the cost of health insurance. And as you can see, just like any other part of an employer supply chain, there's quite a bit of difference among, as far as we can tell, adjusted for most of the things you want to adjust for, in how much total health insurance spending per commercially insured, is just a way of saying non-Medicare, non-Medicaid person per year. This was done back in 2012. But you can see think of this as a gauge of value, with the vertical axis representing the best available information on quality of doctors and hospitals' performance, and the horizontal axis representing how much health insurance fuel is being burned per person per year, taking into account not just how much the insurance company pays, but also how much the employee pays in cost sharing. And basically, the way to look at this is the northwest quadrant is good. That's where you have high quality and low spending. And the vision is, what can we do, including incentives for employees to select more cost-effective providers and to take better care of themselves? What can we do to move from today's positive value oval to tomorrow's, which would be even better and cheaper forms of healthcare delivery, cheaper both for the employer and the employee. That's the vision. And so the next slide will sort of articulate, what then happened once people who run benefits programs for large employers began to get the message from their C-suites, hey, why don't you begin to manage this area of our expense more actively? And it's always been, my perception as I've been actively involved in this, in connecting both with the people in the C-suite that the CEOs delegate this to, the so-called HR VPs or employee benefits managers, as well as the CEOs themselves in some of my consulting relationships. And what's interesting, there's a very famous health economist who died recently, who referred to the people who are responsible for managing employee health benefits in employer-sponsored coverage. He referred to them, somewhat tongue-in-cheek, as Republican social workers. That is, they believe in incentives, but on the other hand, the way it works, if you're ever in one of these jobs, is if the CEO gets too many complaints from employees, then the employer, the vice president for HR, is considered to be ham-handed, and his career prospects, his or her career prospects, are dimmed. So they've always approached this, timidly, and they've tried a variety of things. And this just is in a rough sequence of things that they've tried in an effort to lower the cost of good health care. It began with something called PPO discounts. The notion was, why don't we just go out there and tell doctors and hospitals if they want access to our populations, they got to give us a price discount. They did that. They then got them a little bit of progress, but not a lot. And so then they moved on to something in the 90s that they called managed care plans. The idea was, well, can't we just make all doctors and hospitals and all health insurers kind of do like Kaiser does? Kaiser Permanente seems to deliver good care that people like, and the premiums and the out-of-pocket costs are more moderate than others. So can't we just shift that expectation onto all American health insurance companies and providers? And that was tried. It actually appeared to work quite well, but there were these very publicly visible excesses that led to a lot of criticism, both by the media and some very graphic portrayals by Hollywood, such as a movie called John Q. that came out at the height of the so-called managed care backlash, and as a result of that, the employers and the insurance companies pulled back. And then we entered something called consumer-directed plans, often with a wellness component. The idea here is that let's incentivize our enrollees to behave like Adam Smith's vision of consumers. Let's incentivize them to pick better, cheaper care. And wellness programs refers to the fact let's also encourage them to engage in better health behaviors that'll result in fewer illnesses or a slower progression of chronic illnesses. That worked somewhat, but it has been far from an adequate solution to the rate of rise in healthcare spending, and it's resulted in controversies maybe we can get into during the Q&A. More recently, there have been other attempts, for example, take advantage of a major movement in reform in healthcare delivery called patient-centered medical homes. A lot of employers, particularly those that had geographic concentrations of employees, began to encourage their people to use what they hoped would be more cost-effective forms of primary care. Again, all these things show some evidence of effect, but not enough to kind of stem to offset the size of the problem that they originally intended to address, which is healthcare spending growth in excess of revenues coming in to public or private employers. More recently, the last two items on the list are being pushed forward. It's a little bit early to judge, but let's move on to the next slide. So the bottom line is that despite this sort of 35 years of trying a variety of things, healthcare per capita spending in the U.S. across all health plans, not just employer health plans, continues to outgrow money coming in to pay for healthcare. And so healthcare, as you probably know, has grown from 4% to in excess of 18% of national American income. And many refer to this as healthcare's confiscatory impact on America. There's been interesting RAND studies that shows that when healthcare consistently outgrows spending in other categories, that it actually diminishes wages and employment growth in industries outside of healthcare. So there's some secondary effects above and beyond some of the effects that were described by Larry and Noam. But this shark keeps this could be described as a national problem in jaw misalignment, but a lot of creative people have tried to do something about it without making employees mad, or not making a lot of employees mad. And generally speaking, we have not succeeded in closing this shark's jaws. Move ahead. So road ahead, and then I'll stop here, and we'd love to have your comments and engagement. First, one of the things that I was asked to sort of comment on what I see in my ongoing role as medical director of the Pacific Business Group on Health, which is I think probably regarded nationally as the most activist and large congregation of large employers attempting to improve value of healthcare, particularly for private sector employers, but increasingly seeing that they also have to be active in helping make change across all payer types. The first thing I would point to is a rising opinion among the people that, who I have a chance to speak to, who are the HR managers of big employers, both public and private, and they're in turn providing me, insights as to what their CEOs are saying to them. And one of the things that these CEOs are saying, particularly CEOs of companies that, that address that, what both Larry and Noam talked about, which is employers that have a lot of low-wage workers, is a sense that, that using rising deductibles and rising forms of patient cost sharing, as illustrated by Larry's slide, is kind of reaching kind of an endpoint of how much further you can push it. And there's I think what I sense is that both the benefits managers and the employers have said, when everything else, all those other things on the list weren't enough, we began shifting costs onto our employees. But now, as we for example, become aware of articles such as investigative great journalism like Noam is publishing, and information that's getting out into the media courtesy of Larry's surveys, there's a sense among many employers that, particularly for those with low wage employees, that shifting greater share of cost sharing it may be at the end of the line. Not all feel that way, but it's an increasing sense. And this article I've extracted down below, this goes into more detail. Some of the ideas that have been tried before, where there's more of a sense of optimism now, that I think is likely where some of them will go, will be steering to higher value clinicians. If you go on, Google, search on the Harvard Business Review, you'll see a recent intriguing report from Walmart on a program that they put into effect to send their employees that have been recommended to have spine surgery, all expenses paid, to centers of surgical excellence around the country, where a rather mind-blowing thing occurred, which is half of the employees who had been recommended by spine surgeons in their local communities to have spine surgery, when they got in the hands of America's highest quality neurosurgeons and orthopedic surgeons, were told that surgery was unlikely to benefit them, and were instead decided to pursue non-surgical therapies that were likely to create more benefit for them at much lower risk of greater pain and disability in the future. So this notion of narrowing networks based on evidence, based on quality rankings and total cost of care rankings, is beginning to rise again as a form of an alternative to rising increases in patient cost sharing. Another effort that PBGH has particularly gotten actively behind is beginning to address lowering prices for healthcare. The idea being here that if the price is paid or lower, it'll put more pressure on doctors and hospitals to begin to look at what's going on among their peers in the Northwest quadrant, and begin to move the whole herd, toward the so-called value frontier in the production of good health care. And for example, PBGH prominently testified in recent Senate HELP committee hearings on surprise medical billing. And the reason that PBGH put a lot of its purchaser clout behind curbing surprise medical billing was out of a recognition that the ability to use surprise billing if a hospital or doctor is out of network also is very inflationary with respect to negotiated prices. Because if you're trying to negotiate a favorable price on behalf of a self-insured employer or an insurance company representing a self-insured employer, and the hospital negotiator or doctor group negotiator knows that if you don't come to an agreement, it can simply charge your employees, 3 to 6 times Medicare payment rates, it does result in in an inclination on the part of private purchasers or insurers to roll over and agree to whatever the price increase is being proposed, and so it's inherently inflationary and keeps those sharks' jaws open. Let me pause there and turn it back to Michelle for interaction with those in the audience.
Thank you so much, Arnie, and to Larry and Noam. We're now going to open this up to your questions. So please go ahead and type any questions you have into your control panel, and we'll call on you. And well, we won't call on you. We'll read out your questions. Just to get us going while those questions come in. One question from us for you, Arnie, and maybe others want to weigh in, which is how much can employers do in the face of these inexorable trends of rising prices and consolidation of hospitals and providers? It seems like it's hard to find room for optimism here.
Well, I mean, the reason I cited the Walmart example is there have been successes. But the reason I wanted to also show the shark diagram is that if you say, well, have the successes so far been enough to realign the shark's jaws? The answer is no. So the greater the perceived pain experienced by the employer who's trying to keep their employees happy, the more bold and the more innovative are the experiments that the employers try. But I think, on the other side, I think the fact that the shark's jaws remain open and the fact that this fallback on increased patient cost sharing, that both of those kind of illustrate that so far, the cup is could be characterized as perhaps less than half full. But absent a difficult to arrive at legislated solution, the employers continue to innovate and hope that they will find a combination of interventions that will be enough to realign the shark's jaws.
I would just add, this is Larry, that a lot of what has driven cost increases in healthcare is price increases for physicians and hospitals and prescription drugs. And employers, I mean, the way employers can get leverage over prices is by narrowing the networks of physicians and hospitals that they contract with. And in general, employers have been resistant to doing that. Employers offer health benefits primarily to attract a quality workforce, and at least the perception has been that a narrow network of doctors and hospitals is not something that would be attractive to prospective employees. So that's left employers with at least a limited toolbox of tools to push back on providers and high prices.
We have a question from Steve DeMaio. He asks, did you study the influence of out-of-pocket annual limits after people meet their deductibles? People still continue to pay until they meet those limits, just not at the same rate, yet they are capped under the ACA, so that's a positive. How does all this factor into people's behaviors and calculations about the value of employer coverage?
This is Larry. I can start there. So one of the things the Affordable Care Act did was require all insurance plans to have an out-of-pocket limit, a limit on how much employees would pay in a year towards deductibles, co-insurance, and co-pays. And that's had some effect on, it's had a lot of effect on plans in the individual insurance market, which tended to be quite skimpy. It's had less effect in the employer market because the vast majority of employers already had out-of-pocket limits that were lower than what the ACA required. So it's led to some improvement, but not widespread. I'd say particularly for people with expensive illnesses, the bigger effect has come with the prohibition under the ACA of annual and lifetime limits on coverage. So people who, had $1 million in medical bills would find their insurance cut off before the ACA, and that's not the case anymore.
This is, we didn't study it in the context of this project, but one thing that did certainly come up in a lot of the interviews that we did with people in high deductible plans was this sort of dual, particularly those who were very ill or had family members who were very ill, was this dual sense of sort of frustration with what the deductibles meant for what they had to spend, with still a sense of gratitude that A, they had health insurance at all, and B, that it did have an out-of-pocket maximum. I mean, I think it says something about the sort of precarious finances of so many Americans that even with a cap of, $6,000, $7,000 for an individual, higher for a family, most people don't have that kind of money lying around to pay a huge medical bill, even though they are protected against potentially, a huge catastrophic hospitalization or an accident. The other thing that we are going to get into in that context is in the story I mentioned about shopping. One of the arguments, Arnie, you could certainly talk about this far better than I, that was made to sort of sell people on the idea of these high deductible sort of quote unquote consumer directed plans was that if patients had quote unquote skin in the game, they would become shoppers and they would compare MRIs and hip surgeries the way they compare washing machines and office supplies. And that has certainly not happened for a number of reasons. But, I was just out last week interviewing a family in Indiana who had a disastrous experience trying to shop for medical care and are now about to have another child. And, they're very frank about the fact that they said, well, we might shop around a little bit, but if something major happens and, the baby ends up in the NICU, we're going to blow past our out-of-pocket maximum. And at that point, who cares how much the cost would be? Because we're going to pay the same amount either way. So sort of a number of different complicating influences, it seems, with the out-of-pocket max.
I have a question from Ann Holmes, and everyone should feel free to send your questions to our control panel. She asks, have you studied the effects of the no surprise charge laws in effect in California on costs? Is it too soon?
We haven't.
This is Larry. We haven't. I mean, one challenge with state regulation of surprise medical bills is that state regulation cannot reach self-insured employers, and in fact, most people with employer coverage are in a self-insured employer plan, where the employer is contracting with an insurance company or a third-party administrator to administer their health plan, but the employer is actually paying the claims and taking the risk. And state regulation can't reach those self-insured employers because of the federal ERISA law. So the only way to provide protection from surprise bills for people in self-insured employers is with a federal law.
We have a question from Tyler Young, who says, Dr. Milstein said that one thing employers are trying now are the ACOs. Is there any or much evidence that ACOs are moving overall spend down? And Arnie, maybe in answering, you can just give a quick summary of what ACOs are intended to do.
Sure. So the idea underlying ACOs is if you can think of it as sort of a reboot of the managed care movement. But the notion is that yes, you as a self-insured employer have an administrator that administers the plan, but they in turn help you contract, typically regionally, with doctors and hospitals that are willing to take accountability for what will happen over the next year or multiple years with respect to per capita spending in your employee benefits plan, and also take responsibility for meeting certain quality targets, either maintaining quality or improving quality. And the results, I think it's fair to say so far, I'm not sure I can quote a systematic national well-done research study of private ACOs. There likely have been some, but I can tell you what I can do is sort of report anecdotally on the experience of some of the PBGH employers that have engaged with ACOs, and to say that the results have been decidedly mixed. There have been some ACOs that have actually met their cost of care and quality targets. There have been other ACO arrangements in which the ACOs failed to meet the targets, but they wrote the employer a check, to essentially offset the failure. So the employer, at least financially, was in the same position as they would be if the ACO had succeeded. And there also have been some circumstances in which the ACO fell quite a bit short of its cost of care reduction or quality improvement targets, and in which the employer, declared a failure and is now thinking about the painful process of deconnecting their population from the doctors and hospitals whom they, several years ago, under the promise of the ACO contract, encouraged their employees to begin using.
I have a question for Noam and perhaps also Larry, which is that you have entered into this collaboration where you came up with a plan for gathering information that would then be part of Noam's stories. And so my question is, what are the rules of engagement for that? What would you suggest to a reporter who's thinking of doing something like this, and also for the think tank partner to be aware of in terms of the limits versus, say, a more standard think tank to think tank collaboration?
So Larry can certainly talk about KFF's experience with this, but KFF has done a lot of these media partnerships in the past, and so they have a pretty good understanding, I think, of where the lines are. We agree. We worked together on developing questions, in this case, for the poll. And we agreed that KFF would not have any editorial control over what the LA Times would publish, but we relied on KFF to fact check what we were doing, and we coordinated with KFF to release our first story at the same time that KFF released its own report based on the survey, and we had similar kinds of arrangements with the other two research partners in terms of timing and in terms of editorial control. I think maintaining that editorial independence is critical, but it also should not stand in the way of, in my view at least, of communication between the media partner and the research partner, because I can say already that KFF has saved me from making a number of errors in reporting on some of the results. So it's good to have them as a backstop.
And this is Larry. I would echo what Noam said, that for any analytic organization or think tank wanting to enter a partnership like this, and we've done dozens of these, you have to go in recognizing that the news organization has to have full editorial control, that's the only way it can work. And you've got to just live with the fact that the reporter might have a somewhat different take than you have, and a different perspective, and that's the breaks. I would also say that it's important to work with a smart reporter like Noam, who can make great use of the data in their reporting.
Thank you. And Noam, a follow-up question. You mentioned using GoFundMe as a tool to get real people, and it seems like it's a rather crude tool. I mean, you can't search in such brilliant ways. And so any suggestions or strategies for reporters on how to make that work for you?
I mean, it is crude. I don't know that it's any cruder than, going to, the Multiple Sclerosis Society and asking if they have, if they know of any patients they're working with who fit the following criteria. I mean, as any reporter knows, finding quote unquote real people for stories is a bit of a casting call, and you kind of have to dig deep sometimes to figure out, make sure that all the facts align and so forth. GoFundMe specifically does not, as you noted, make it particularly easy to search. It does make it easy to contact people, and I'm certainly not the only reporter who has found people on GoFundMe to write about for any number of different purposes. In my case, the story is very explicitly about the GoFundMe experience, so it was very on point. I didn't use GoFundMe to find patients who were struggling with deductibles. I went there to find people who were using, online crowdfunding tools like GoFundMe.
Thank you. We have a question from Chris Waljasper, who in some ways is asking about whether it still makes sense to organize insurance through employment, wondering about other models, for example, the Farm Bureau or the American Farmers Union that provide insurance options as part of membership. Are they at all immune to some of the trends that we've been talking about?
This is Larry. I can start. I mean, there's been a lot of interest in association health plans. The Trump administration has relaxed some of the insurance rules for associations that offer health plans, and I would say that's the big trade-off. That in these association plans, it may provide a new option for people, particularly people who would otherwise have to buy insurance on their own or who move from job to job within the same industry. But at least the way it's been implemented by the Trump administration, some of the rules that would apply under the Affordable Care Act, like limits on premiums, variation due to occupation or industry or age or gender wouldn't necessarily apply. And farm bureaus in particular, there have been a few states that have kind of sought to do an end run around the Affordable Care Act by allowing farm bureaus to offer health coverage that looks like health insurance but isn't called health insurance and is therefore exempt from all of the rules in the ACA.
This is Arnie Milstein. Maybe I can just add that, for decades, one form of multi-employer pooled approach to purchasing has been permitted under the Taft-Hartley labor laws that were enacted, decades ago. Employers whose employees are in the same labor union have been able to get together and form multi-employer benefit funds, and then try to do across a multi-employer and in collaboration with a union which has an equal number of trustees as these on the health benefits plan management board. They've tried to, they've struggled with the same problems I've described for employers, and I think it's fair to say that at this point there is not a preponderance of evidence that by pooling employers together, and in this case, improving the voice of employees through labor union representation, so far there's not evidence that those plans have, on average, substantially outperformed the employer-sponsored plans. So pooling may have some benefits that we have not yet taken advantage of, pooling across employers, but at least using that as our frame of reference, there's not a preponderance of evidence that it has worked better than individual employers trying to solve the problem themselves.
Well, I want to thank all of you who have shared your expertise with us and to thank our audience for their excellent questions. With this, we are going to end our webinar. Just a reminder that we will have an archive of the webinar at centerforhealthjournalism.org a little later today. And shortly, we'll be sending all of our participants a survey that asks you both for your responses to this webinar as well as which topics you might be interested in for our next one. We take your feedback very seriously, so please take a moment to fill that out. Thank you all and have a wonderful day.